Hi guys, this is Amy. We're going to talk about bleeding times. So we're going to go over prothrombin times or PTs. We're going to talk about INRs. We're going to talk about partial thromboblastin time or PTTs, and then we're going to talk about activated partial thromboblastin times or APTTs. Okay, a PT basically measures, and an INR, how long it takes for the blood to clot. There are certain blood clotting factors that are needed to make blood clots, and blood clot. And you know from MedSurg 2 that we talked about DIC, we talked about von Willebrand's, we talked about hemophilia, and how the blood clotting, the clotting factors were necessary to form clots. And if you remember, we've discussed that the components of the blood that must be necessary for blood to form clots are platelets, clotting factors, and fibrinogen. And so if we have a disruption of any of those clotting factors, or maybe anticoagulant therapy that is being used, it can prolong this clotting time. Prothrombin is actually just a clotting factor. It's factor 2, and it's made by the liver. It is necessary to have vitamin K, though, to produce this prothrombin. So if you have a vitamin K deficiency, then it can affect your PT-INR. PTs are typically done in correlation with liver tests. So we may see ASTs, ALTs being performed with this because the liver is essential in producing and taking that vitamin K and producing the prothrombin, which again affects clotting time. Things that's going to increase the prothrombin time or PT, Coumadin, anticoagulant therapy. This is not a test used for heparin therapy. This test is used for Coumadin. And when someone is placed on Coumadin, you will see PT-INRs very every day for a while till we get the therapeutic range. We'll talk about that here in just a moment. But we need to monitor that before we give the next dose of Coumadin. And so typically these tests are done the same time every day to aid in consistency, because we don't want to accidentally give Coumadin until we've seen that result, because we may need to adjust the dose. We may need to give more or less of the dose to make it therapeutic. If a person has low levels of clotting factors, and it looks for 5 different clotting factors. Remember, clotting factor 2 is your prothrombin, but regardless, if we have low levels of clotting factors, that can certainly have something to do with it. So hemophiliacs, von Willebrand's, those types of things. Well, let's talk about this increased use of clotting factors in instances such as DIC, or disseminated intravascular coagulation. If you remember, I know you thought you'd never have to hear that again, right? But if you think about it, what happens in DIC is that we have millions and millions of these little clots in the circulation, and it is, to make clots, you have to have platelets, fibrinogen, and clotting factors. And if all those clotting factors are used up to form these clots that really basically are no longer helpful, if you were to start bleeding, the clotting factors are all used up, you can't form clots when you need to. And then obviously if we have problems in the liver or with vitamin K, where that prothrombin is not produced. The INR is always reported with the PT. The INR is the International Normalized Ratio, and it is a way of standardizing the results of the prothrombin time. What happens is each laboratory does the test just a little bit different way. And the prothrombin time, or the PT, is affected by the type and amount of reagent used. And so if they use different reagents in the different lab facilities, it could be an inconsistent way of monitoring. Say you have a PT done at Ohio Health and then you go to Mount Carmel, and they can't use the same PT because they may use different reagents. Now what they can use is the INR, and sometimes PT isn't even reported, but the INR is. So when a person is on Coumadin, we will look at the PT range and we will say, okay, for this lab, our normal PT would be 11 to 13 seconds. But for someone on Coumadin, what we're going to do is we're going to take that range and multiply it by 1.5 to 2.5 times the high end of normal. So let's see, I've got my calculator out. I wish I would have done this prior to this talk, but let's say if our high end is 13, we're going to multiply that by 2.5. It should be 32.5 is the highest range that person would be considered therapeutic within that level, if that makes sense. Okay. Now for the INR though, it is a little bit different. An INR, we are looking for that range if it's a person who is not at extreme high risk for developing clots, such as people with atrial fib. We'll talk about those people here shortly. But if it's someone who maybe had a clot in the past, they're on Coumadin therapy to try to prevent clots in the future, we are going to look at this INR here, and for a person not on anticoagulant therapy, you will see the normal range is 0.8 to 1.1. For people on Coumadin therapy, we want to see that range anywhere between 2 and 3. If the person is very, very high risk, like I said, such as they have atrial fibrillation, we're going to see that instead of being the range 2 to 3, we want to see them at 2.5 to 3.5. So let's say you have somebody on Coumadin, they have atrial fibrillation, they can't come back, and their INR is 2.1. We're going to see the physicians increase the Coumadin until they get into the level of 2.5 to 3.5. If we have somebody who had a clot in the past or are at risk for developing clots, but it's not necessarily high risk, you will see that we want them 2 to 3. So if their level came back at, let's say, 3.3, we would see the physician decrease the dose. Hopefully that makes sense. Now remember that vitamin K is really important in producing prothrombin, and so it is important to understand what foods are high in vitamin K levels. We know that organ meats are beef liver, pork liver, and then there are some other things there. I got to be honest, vitamin K foods, none of those except for maybe broccoli and chickpeas look good, right? Some soybeans, I guess. All right, so again, PT was for Coumadin. Let's move on to PTT. PTT measures the time it takes for the blood to clot, just like it did for the PT-PTT. Both look for the time that it takes for the blood to clot. We're not going to get this in depth, but basically one looks for the intrinsic clotting factor cascade, the other looks for the extrinsic clotting factor cascade. So if you ever wondered, well, what's the difference? Additionally, PTT looks for maybe some different clotting factors than the PT did, okay? Now, what you may see is your facility may have a PTT, and then some facilities have an APTT, and some you may see both. Now, this APTT may have a small case A in front of it, but regardless, an APTT is an activated partial thromboplastin time. The difference is it tests for the same thing. It's not testing for anything different. The only difference is in how they run it in the lab. For an APTT, they put in a special reagent that increases or it speeds up the clotting time. An APTT is considered more sensitive and has a more narrow reference range. For whatever reason, where I used to work, my first job only did APTTs. Some places most places only do PTTs. I'm not sure if it's more of an expensive test or more of a challenging test. I'm not really sure, but know what your facility uses, because depending on if it's a PTT or an APTT, it will change the reference range for normal values. Some people use these interchangeably, but I will tell you that they are not actually, I mean, they do the same thing. They test for the same thing. However, they do have different reference ranges, so that's really important. So what kinds of things do increase your PTT? Heparin does, low levels of clotting factors, and increased use of clotting factors such as DIC. Pretty much everything we just said about prothrombin time except for the heparin. All right, so this is very similar to the PT as far as our therapeutic range for this as well. Remember, I did just say that PTT and APTT measured for the same thing. They had different reference ranges. Most places are going just with the PTT. That would be the one I would most likely memorize, 60 to 70. Trying to think of a good way to help you memorize that. Don't have anything off the top of my head. But let's say we have take the high end of the reference range and multiply it by 2.5. So if a person on heparin came back, 175 is the high end of the reference range for that. So if someone on heparin comes back at 202, they would decrease the dose of heparin. If they came in, let's take 60 times 1.5, that would be your low end of reference range, would be 90. So if they came in between 90 and 175, they would be considered within therapeutic range. However, I will tell you that everywhere that works with patients on heparin has a heparin pathway or protocol, and it's standing orders, and it's sort of like a sliding scale for insulin. It will say if the PTT comes back at this level, adjust the heparin by either giving a bolus or stop it or whatever the pathway says. That is all I have for that. So if you have questions, see me in class.